The first 5 minutes of a mass casualty incident. What should it look like? What are some of the common mistakes? That's what we're going to talk about in this episode with Rommie Duckworth. Sam, have you ever had to control an MCI or be like the first responding unit to an MCI?
Yeah, I just pretend like there's not as many people as there actually is until somebody who's like really into those NIMS classes.
First come, first serve.
Yeah. The fire department shows up with somebody who actually knows what they're doing with an MCI. I've always found that that's the best approach. You know, just pretend like it's not happening until somebody shows up and it's like, I love MCIs. No.
Yeah, what is it? The squeaky wheel gets the oil, right? That should apply
exactly.
to MCIs as well.
No, with the triage methods are pretty difficult. One of the things that Rommie said in there was that there was like no best system. And I was trying to put that to the test a little bit because there are a lot of options out there. It's like, the start that includes like the jump start or SALT or I had to look up that one. Did you see that 10-second triage?
Yeah,
I had never seen
European.
that before, but I thought that was pretty cool. Mass, like meta. And so I took as many as I could find and I like separated their variables and I was getting like nerdy with it. And I took those and I put them in like a machine learning algorithm after I separated them all out. And so the points that I was using was like, what's the primary focus of it? The speed of the triage. And then I put the assessment items in there. Like, what do you do with breathing, pulse or circulation, mental status assessment, stuff like that. Does it allow for life-saving interventions before the triage? What are the categories you put them in? What's it best used for? What are the limitations and stuff like that? And I'll be damned if there's no perfect system. It is really like it's either fast or maybe it allows you to do some type of treatment, I guess, before the triage is done. And there's like really specific systems for that. But one thing that I noticed in here, and it reminds me of SIRS criteria a little bit, where let's say you have something that assesses like objective things, like is the heart rate above this or is the heart rate above this or whatever, respiratory rate, heart rate, stuff like that. Like with SIRS, the big joke about it is that you could stub your toe and you could set off the SIRS criteria, right? Because your respiratory rate goes up, your heart rate goes up. And then, so there's like that category of things, which I find a little bit maybe difficulty. I can see how that would like lead you in the wrong direction because people are amped up, But then you have other things that are more objective, not more objective, but just like visually you're able to just make a decision on like, is the mental status really bad? Like this, everything is crazy around here and this person's barely responding to me. Like it's something you notice right away. Or is there a lot of blood? Or does this person have obvious penetrating trauma? Are they at a huge risk for something that they've been exposed to, whether it's the weather or like some type of chemical agent that they were exposed to? Like those are very, it doesn't take much. I don't want to say it doesn't take much to train on those things, but it's almost something that you'd intrinsically think about. So I like the things like the 10-second triage where you're just getting through it real quick. You're not stopping and you're not taking like vital signs on this person who's like really amped up. And then, there's a big decision point about, do you do treatment or not before triage. And anyway, going through all these things, I think, the best one is the one, I think he said this in the podcast, that it's whatever you're comfortable with and what you've trained on, because the last thing you want to happen is to show up and start thinking like, man, which triage do we use? Or like, man, I haven't taken a look at these cards in a long time. Or does this mean we have to take a pulse on every single, or the classic, like, are you going to count respiratory rate on every single one of these patients that you see? It becomes difficult.
Yeah, and I can appreciate the approach he took with this, because if you're explaining a triage system to a wide group of people, you don't want to get as esoteric into like, this is what this one teaches and this is what this one teaches. And he talks about visualizing a river and not wanting one particular area to clog it up. And that could be getting patients to where they need to be, right? And maybe a hospital, maybe a tent where they can help them out over here. And so he did an excellent job explaining this. I've heard Rommie speak. I know we both have several times. Excellent. Yeah, excellent presenter. So I think you guys will really enjoy this. Rommie, tell us just a little bit about yourself going into it, and then I'll get into the MCI stuff.
Sure. Well, my day job is as a fire captain and a shift commander for Ridgefield Fire Department, a small combination fire department in Connecticut, about an hour outside of New York City. We do paramedic ground transport. We got 4 ambulances. I've formerly worked for private and municipal EMS. I used to be a critical care paramedic for AMR, and I've been doing this for a while. But when I'm not at work and I'm here at home, I write creative content for EMS publications, magazines, and textbooks.
Yeah, and you have an excellent presentation style, seeing you in person, very engaging, and kind of the person that can speak to my brain on things that I don't feel like I'm that knowledgeable about. And that's MCI, right? Operations section was an area where I was like, well, let me get back to the EKG or airwave stuff or ultrasound. I've never been one to be like, oh, I'm going to really study up now. I want to be the operation guy. But that kind of goes hand in hand with some of the fire stuff as well that you do. And so watching your lecture that you gave on YouTube, I was taking some notes, right? And I was like, we should do an episode on the do's and don'ts within like the first 5-10 minutes of arriving at the scene. Maybe maybe you don't know of a mass casualty incident. And, I feel like every time we kind of talk about this, there's always current affairs or current things that are happening. So there's no shortage of scenarios where we need to be prepared for this. And so I don't want to say any more. I just want you to imagine you and I are going out and we think that, there's a car accident or something. We think there could be multiple patients, and kind of take it from like the dispatch side. I think that's probably the earliest to take it. Or you may say even before that, like prepping, but let's just say we're on shift. We're going out for something where there could be more patients than there are providers. Where does your brain go? What starts to percolate?
Well, like you say, it depends on the situation that you're working in to some degree, what resources you have behind you, how things are structured, how much training that you've received either in general in operations and mass casualty incidents or specific operations for your large or small organization. But for all of that, because like a lot of people, I've worked and volunteered in different types of organizations. For me, with my early history of just stumbling across and being involved in different kinds of MCIs, I've really thought about this a lot and really focused on how, for me, at 3 o'clock in the morning, when I'm looking through the windshield at something bad, like you say, or for anybody else that I'm working with, what do we do when we first pull up and it's just what we see is overwhelming? And so I break things down into 3 steps because that's about all we can handle at one step at a time. So for everybody, we got to stay mission focused on the individual thing that I'm doing. That's how I don't have to manage the whole thing. It's going to be overwhelming. So I got to stay focused on our individual mission from the initial chaos when we may be the first responding, or like you say, we're there in the first few minutes and it's just overwhelming chaos, through the evolving complexity of the incident. So the problems that we have initially is that we're overwhelmed and because of the chaos. And as it goes on past that first 5 minutes, it's the complexity of the structure of the incident that can also be difficult. So when we stay focused on our mission, that mission is 3 steps, man. 3 things that we got to do. Number 1, stop the killing. Number 2, stop the dying. And number 3, move patients forward. Those 3 things. If there's something killing, we got to do what we can to stop that. Then once that's addressed, and only once that's addressed, we can stop the dying and start our treatment. And the treatment can occur, but only while patients are moving forward. We can't do anything that's going to be slowing down forward movement of patients, because that's the real gear change we have to make as providers from our normal operations, where we're tucking in and we're doing the best for this individual patient, and a mass casualty incident where patients need to continue.
And I love, this is the first time I've ever heard you called it a patient generator in that talk. And you're like, stop the thing that's generating patients. And so I want to start with that a little bit, because there may be something that, you think of like a school shooting or something like that, or an active shooter incident where maybe you're not the one that can go in and actually stop that. But you can't really stop the dying until the thing that's stopping the generating of patients is stopped as well. So that's, where law enforcement is going, that direct to threat. We've seen some changes in the approach to that. But what type of situations in EMS can you think of that are where we can actually stop that generation of patients?
Well, even advocating for something that you may not be able to address. So identifying and advocating, and it can be something as out of the ordinary, but unfortunately possible in every community, like you were describing, an active scene of active violence, an active shooter event, or somebody driving into a crowd, something along those lines. So it may not be your capability or your primary job to be the hands-on with that, but you need to connect with law enforcement or incident command and make sure that's happening. But it can even be something simpler that we all deal with: motor vehicle collisions. Maybe it's a school bus incident or just multiple patients, and the patient generator is the car crash, and that's already happened. But stop the dying, pardon me, stop the killing in that case. We're looking at it, okay, what potential patient generators do I have? And you may look and go, traffic, someone can get hit. We're going to generate more patients. And that may be some of my patients getting out of their vehicles and wandering into the road, or it may be responders who are working in an area where traffic is flowing by. So I may need to connect with cops, incident command, fire police. I need to advocate whatever works in your system to stop the killing, so that we have to lock down that patient generator as best we can before we can start that treatment.
Yeah, and I like that point, because you may say, okay, we came up to a car with an unresponsive patient. Our instinct is to go in and rip that patient out, right? Or a patient that's in a garage with a running car. We just did a blog on Foam Frat about these detergent suicides, where they write, call hazmat before opening the door. You look in, you see a bucket of some chemical. So the stopping of the generation of patients could be stop generating them from the EMS side or from the responder side, not necessarily bystanders as well. So having good situational awareness seems obviously very important here, and is definitely the first big step in managing an MCI. Anything else we should add into the stop the generating of patients side of it?
Sometimes, as you say, you're going to get drawn in, and we tend to picture getting drawn in by bystanders or by the patients themselves. And it can be very difficult to differentiate that in those first few moments. Like you say, you're pulling up, you're looking through the windshield, you got people yelling for help. We can even have other responders directing us in to the patient generator where we could become patients, or they want to go in and become patients. And this is not to say, hey, until everything is secured, we don't do anything.
Right.
But rather we identify the patient generator or patient generators, the traffic, the downed power lines, and we start to make sure those are identified and addressed. Maybe no one's going to pick up those downed power lines before we go in and start treating, but we identify them, we make sure that we go around them, and it doesn't become a patient generator for us. We make sure that other people know, go around those. So it definitely, this is not a scene safety BSI. We don't go near anybody until everything is taken care of. This is just making sure that we're identifying it, and that group situational awareness makes sure that we're not lowering our resources and building up the patients, which is obviously not what we want to be doing in the first few moments of an MCI.
All right, perfect. I think that's excellently stated. Let's move on to the stop the dying. So you and I pull up, and there's nobody else there. And we're going to go into, I guess it depends on the system, but sometimes they'll say the first arriving unit is going to assume command. But we also have to do the triage process as well, right? So we have all these patients, maybe the 4 or 5, 6 patients, whatever. for me, it almost seems like when a baby's born and you're like, I got to clamp the umbilical cord, calculate an APGAR score, I got to suction in the mouth, and then, there's all these things that you have to do. How do I stay mission focused? It's a car accident. We're not going to get into traffic, or the threat is stopped. The patient generator is stopped. But now I gotta make sense of all of these patients that I have and try to do the best for the most amount of patients. Like, how does your brain, what's your mental model for thinking through that?
In two directions. The beforehand, when I'm prepping up, and the way that I've prepped up my system, and we're going through a year-long mass casualty incident training program right now, focusing on pediatrics. And so I've had the opportunity to take a look at the research on triage systems, talk with some of the people in the military who are really leading, understandably, mass and multi-casualty incident, even though it's a little bit different in the military, but really looking at those triage systems. Because when people think MCI, they think triage. And they get all bogged down, like you say, in these triage systems. And I wouldn't talk bad about anybody's favorite triage system in the whole world that they may love and cuddle with at night, but none of them work. That's what it comes down to. There is none that's proven in any way better than the other. And what we know is that forward movement of patients, that winds up improving outcomes. So if you're practiced, if you're both competent and confident in your use of triage, and that's the triage system that everyone goes to in your system, that's fine. And I don't care if it's START, or the UK uses 10-second triage now, which is a very fast and practical and pragmatic system. That's all great. If in the moment you said, I'm not sure what to do, I'm not telling anybody to not obey your protocols, but a triage system that you have to fumble with is going to be far worse than looking at the patient and making a pragmatic decision as to their priority. Because what we need to remember is that triage is not actually about the patient's injuries. It's not triage for their treatment. It's based on our assessment, but triage is there to decide which patients must move forward first. That's what it's about. Now, I realize that triage tags can also wind up getting patients moved forward to the appropriate resources. Like, I get that. But our number one thing is that triage systems are to decide who moves forward first, because we're moving them forward to the right resources and ultimately definitive care, which is not going to be on the scene. So whatever triage system you have, if you're competent and confident, go for it. It'll work great for you. But if you're not competent and confident, the best thing for the patient is a pragmatic decision for red, yellow, green category, 1, 2, 3, or whatever your system is using, so that we can move these patients forward rapidly towards the resources. Because spending a lot of time triaging them, either individually or triaging the whole group, is just going to not only not get your patients to the care they need, it's going to bog down the entire incident. And we've seen that over and over again. And I don't want to bore you with the list, but it's that lesson that we're supposed to learn from every after action report for the past 25 years that just crops up at every incident.
Yeah, no, excellent points there. To dig into that a little bit, in your talk that I watched, you discussed you think a two-person approach to triaging is probably best. And that made a lot of sense to me, because you don't have one person getting so mentally stuck on this. What do I do? What do I do? Because you already have the next person going on and triaging. So how do you separate those two people? One is triaging and one is treating. What does that look like?
Yes, that's my preferred. Now, again, it's not, I realize that it's not always practical, but
Right.
there are so many advantages. That's how I've set up my system. And again, there are very few MCI systems where they won't at least allow that for you and your partner. And that's exactly what I do. So whatever treatment you can perform that doesn't stop forward movement of the patient, go for it. anything, opening an airway, in some cases, decompressing the chest, whatever it is that you can do, and then leave the patient that's appropriate within your capabilities and all of that. If it doesn't slow their forward movement and your forward movement, it's okay. Follow your local protocols. So if you have one person focusing on the rapid assessment and going, okay, they're going to need, let's tilt their head, drop an oral airway, they're red, and move forward, then that tends to work really well, because the person who identifies and does the rapid assessment, when they're ready to move forward, the other partner can do the physical skill, but when their partner moves away to move on to the next patient, they're going to be pressured to just do the thing they're doing and move on, because everything in our training is continue to treat this patient who's not breathing. Our reflex skill, both our prefrontal cortex and our muscle memory are telling us stay with this critical patient when these patients need to be identified and moved forward, and we need to do the whole group.
Yeah, I like the cognitive side of that, because anytime there's like an assembly line, where you have like a bunch of people doing stuff, and before this person can do stuff, you have to hand them something, and before they can do it, they have to do it. There's this internal pressure it puts on when you see like all of your stuff stacking up over here, and you're like, man, I'm the weakest link in the chain. So if you're sitting there diddle-daddling around with a needle compression or trying to mess around with something, and you look and your partner's already like 4 or 5 steps ahead of you, it's that pressure. Like, I got to speed this up. Like, I'm doing something wrong or something. There's some sort of hiccup in the river of patience that you talk about, which I love that. You said, well, I don't want to give it away, but you said to kind of imagine the scene like a river, and the end of the river doesn't necessarily mean they're at a hospital. It could mean that they're in some place where they can receive care, but you just don't want to have these things that are clogging up the system, right? So speak to that just a little bit.
Sure. Well, as you say, if we can move in pairs and at each step of the way, for all of the different, wherever you happen to get assigned. But again, we're focusing on those, hey man, you pulled up and you saw it through the windshield either first or in the first 5 minutes. You and your partner are just automatically holding each other accountable that way. So it's not something that is, you have to go, okay, this is a special mode and I have to specially think about the special thing. You're going to be overwhelmed by the context. And this is one of those few times where when we're teaching it in the classroom, and this is what makes me passionate about teaching it, is often there's a huge disconnect about what we say we should do when we're in the classroom, not acknowledging the context of just that chaos, right? And so I want to make things simple for me, and for anybody else. And I picture, okay, if I'm saying we need the patients to move forward, that wherever I happen to be, whatever my assignment is, the patients start where we find them, and I need to picture them like I'm going to put them on a tube and they are going to float downstream. They are floating down the river. And I want that river to be as straight and with as few clogs, bumps, pools as possible. Now, sometimes that river is going to have to bend around a little bit. So maybe where I find the patients is somewhere where I have to move them to a casualty collection point for them to be safe. I have to get them out of the road. Everybody's got to get out of the road, and I don't have a treatment area to move them to. So that tree is our casualty collection point. Everybody post these patients up on that tree. So the river's not as straight as I would like it. It's going to go bend around that tree a little bit. But when I visualize the scene, and I don't have to be the incident commander, I don't have to have a drone's eye view, I can just look around and go, okay, this river's got to flow to that tree, to that parking lot over there. That's a good spot maybe for a treatment area. And everybody's looking at the scene thinking the river of patients. We're all probably going to picture something that, without even talking to each other, is probably pretty close. And maybe the patients pool in as they float down. They float over to the tree. I wind them around the tree, but I'm keeping this river as straight as I can over to that parking lot over there. And that'll be a good treatment area. And they'll be in that pool for a minute. But everybody's thinking, I don't want them in a pool. They may float around in their tube for a minute, but where are they going from here, man? They got to keep going down river. And again, as straight as we can to move them on to our transport, and then as straight as we can downstream to definitive care, wherever that happens to be.
No, I love that illustration. I like, you know what I like about it is it's a big picture view of it. And I feel like when I start thinking about MCI and I start thinking about all of the NIMS classes and things that I've taken and ICS this and whatever, there's so many nuances that I'm like, I'm not going to remember all of this stuff. I'm not going to remember the span of control for this person or that person. But I would have to say, like, if you put a patient in front of me and you said, give them a green, yellow, red, or, expectant or black, like, I feel like I could look at that patient and be like, oh yeah, they need to go right now. They're unresponsive, but they have a pulse. Like, without any system, I could just look at that and be like, yeah, that's what we have to do, But there's no doubt in my mind when you're in a situation like that, that your bandwidth is shrunken down so much that you're trying to stick to the things that you can absolutely fix right there. And I've heard the acronym or mnemonic BATH, bleeding, what is the A, airway, T is tension, and H is hypothermia for the things that you can immediately treat. Do you have a certain one that you like when you're the treatment guy and you're trying to figure out the best way to go through this that you like to use? Is BATH what you use as well? Or what are the ones out there that you've seen?
I like BATH a lot. The one that I have sort of attached myself to is March, for the massive hemorrhage, airway, respirations, circulation, and hypothermia. And again, that's not one better than the other. That's just that's like my favorite splint versus your favorite splint. If we're both comfortable with it, that's the right splint for us, right?
Yeah.
But I feel like it helps me prioritize, and quickly prioritize for the people working with me, what we need to be doing for this trauma. Again, keeping in mind, that, like, as treatment officer, what resources am I going to need to assign to each patient, right? And if massive hemorrhage, anybody who's got massive hemorrhage, we're starting with hopefully BLS. So just about, hey man, anybody can apply direct pressure as long as you're showing them where or how to apply. And once they're in that treatment area, they may need to be stuck with that patient applying direct pressure for a significant amount of time, right? So
yeah, no, absolutely. Yeah. That makes a lot of sense. Well, so we've talked about, stop the patient generator, stop the dying. And next up is what?
Well, continuing that move forward, as we flow down the path, for each MCI position, because as especially for those of us who are working in smaller to medium-sized systems, you may get assigned to not just perform triage or perform treatment, but you may get assigned to run that area. And as much of a fan of checklists as I am, over and over again, I wind up seeing, like, okay, here's this 36-point checklist that you're supposed to orient yourself to right now from that training we did 7 years ago. You're the treatment sector director, and whatever they happen to call you. And so instead of starting to make things better, you're trying to reorient yourself to this big checklist or this wall of text on a reference card. And so again, for me, it's size up, set up, move forward. So whatever the position that I'm in, and this I like because it dovetails with pretty much any mass casualty system, at least any one that I've seen. Like, yeah, you can use your system, and when you're in the position of triage, treatment, transport, staging, whatever, size up, set up, and move forward. I got to size up what's related to me. So if I'm triage, I need to size up my patients and the patient generator, right? I need to set up for triage. I got to have the people and the tags or tape, right? That's what I got to make sure that we have that. And move forward, again, just keeps me on the primary thing that we need to be doing. Yes, the tags and the tape are great, but they only are there to move patients forward to the resources that they need. They're not there as a definitive documentation of this patient's critical injuries.
Yeah, no, and that makes a lot of sense. And I've seen so many different types. There's the types that you can like tie around their hand. There's the ones that go around their neck. There's like little bracelets. But I think your point is well taken that, this is just to keep that flow going. If it's bogging your system down, you need more training, or you need something else on that aspect of it. So we've talked about a lot of the do's and I would say the don'ts, right? Don't bog down. Don't get too task saturated on one thing. Don't just run in blindly and let the crowd set your pace at which you walk right by and generate more patients, maybe even yourself. A lot of the times now that I'm flying, that I'm coming into an MCI, it's been set up and I'm going in and they're telling me, hey, LifeLink 3, you're going to take this patient right here. And I always wonder, like, if you're an ambulance coming in or you're a helicopter coming in, what are the things that are annoying as incident command that kind of bog the system down, but from the standpoint of the responding units, right? Everybody's hearing, everybody wants to come play on the scene. And you mentioned in your talk, like where they respond to, where they're staging, not going directly to the scene. But where does that come from? Or where is your mind when it's like things that irritate you that responding units do? Or maybe not even irritate you, but they just slow down the forward flow of patient movement.
Absolutely. Well, one of the things, even for everybody tends to think of mass casualty incidents as the school bus full of hemophiliacs crashing to the front of the glass factory, right?
Yeah.
It's gigantic. And if it's not that, then it couldn't possibly be an MCI where a minivan crashes into a car with 3 more people in it, for so much of where we are with, or even just a couple of critical patients. As soon as you start getting those critical patients, your MCI threshold does not have to be 10 patients if a couple of them are critical, right? So staging is incredibly underused because people just want to continue doing the thing they normally do. Please just come in and just grab somebody. And that's the thing that annoys me, as what often happens is as an incident commander or transport officer, somebody who's trying to continue that patient flow, I need a resource available that I can connect to the next patient. So for example, as transport officer, I'm connecting patients with transport to destination. Right? I'm putting those 3 things together. That's all I got to keep in mind. But if my transport just keeps coming in and grabbing somebody, that may not be the next person I needed to go, or they may be taking them somewhere I don't want them to go. So whether it's aeromedical or ground transport, we need to make sure that they're going to a staging area and we are able to easily identify the next patient who goes. Ground transport often comes in, both people get out of the ambulance, or the crew gets out of the ambulance, and now what do I have? I've got a paralyzed ambulance. I don't want 2 people.
That's
generally. Again, you could probably come up with a scenario where I'd agree, like, oh, okay, it's a bariatric patient, they're only 2 feet away. Again.
Right.
But generally, driver, stay with your vehicle. I can't have forward movement if a vehicle is in park and there is no one there to drive it, or worse, someone took the keys, which just happens over and over again. Now the whole system becomes paralyzed, and people go, well, oh my gosh, but now you're trying to load up somebody who isn't wearing the same uniform as me in the back of my ambulance. Yeah, that's fine. We'll sort it out. That is not the worst thing that is going to happen today.
Yeah,
we're good. We'll be good. So again, aeromedical, I mean, you have to find an LZ, so you kind of going to have your staging. But just coming in and swooping in and grabbing somebody, often then I lose accountability. And now, as the treatment or transport officer, even if you took someone who looked pretty bad, and you probably would, I'm going to spend time trying to regain accountability when I should be keeping patients moving forward.
That makes sense. I've been in a few situations where the incident command has tried to split up my partner and I. And my personal opinion on this is that is not effective, because typically you have an airway bag and a primary bag, you have your monitor, and when you split up those providers and you put maybe one on a BLS ambulance, you kind of crippled any ALS capabilities you were hoping for. Now, you could argue that all I care about at this point is getting patients to the hospital. I don't care about your ALS interventions that you may do. But if you're calling in for ALS ambulances and all I have now is the airway bag, but all the drugs are in the other bag, it does cripple the situation a little bit. Now, and this is even more the case if you're looking at a aeromedical crew coming in, right? So a helicopter lands, like, we have to leave together. We can't leave on different units. Maybe you could argue if there's a local hospital or whatever. But what is your thoughts on splitting up crew members? Do you feel like there's definitely times where that's necessary? Do you feel like it's if you don't have to, don't? Do you feel like if you split up crew members, you're making the river flow a little better and you're dividing your ALS a little easier? What's your personal opinion on that?
Yes. No, I acknowledge exactly what you're saying. I would prefer to always keep people who are used to working together just from that perspective. And every point that you made about familiarity with your gear, and I'm an ALS resource. So for me to be fully functional ALS, I need to have my gear, my environment, preferably my partner. I totally agree with all of that. What I usually try and let people know, though, is that sometimes you may have to even say add a resource. Okay, so maybe now, presuming ground transport, this wouldn't fly with a helicopter, but you may have to have a different driver. I'm not asking you to put the pilot in the back and having a local volunteer firefighter jump in front. I promise.
It'd be a fun ride, but yeah.
But I find there tends to be much more pushback against that, as in I can't, and I try to open the door where, hey, if this is going to be the best thing for the patient and for forward movement, we may have someone else drive, or just because it's a BLS and a vehicle and you have your ALS gear enough that you can continue as a paramedic, you may need to get in the back. But I say that in the context of, I totally agree with the first stuff that you said. I want to keep people together so they're comfortable, they're with their partner, they're with their equipment. That just works better.
We did a simulation at LifeLink 3, and it was an MCI scenario, right? So we're coming in, me and my partner, and we have 3 patients, right? So we have a patient who's dead. We have a patient and 2 red patients. And so one of the red patients is an infant and the other one is an adult. I can't remember, unresponsive, breathing fast or whatever. And so we do this scenario, and it was the kid is over here, the parent's way over here. I think it was like an ejection from a car, some sort of car accident, And so 2 red patients and my partner and I, it's just us. And we have to split up and take care of these 2 patients. So we're doing this move, where I would say is probably like me, and then, I don't know, on the other side of the simulation bay they are, and we're throwing equipment back and forth. And I'm like, hey, can you throw me a size 3.5 ET tube? And they're throwing it to me, and here, throw me the BVM, and I'm throwing them the BVM, and you probably see where this is going. But we're doing this, and I'm like, good Lord, this is difficult. And then at the end of it, the person who's leading the simulation mentioned, well, why didn't you just pick up the baby and move closer to where they're at? And I'm like, oh my God. Because there's this thought process that I have to treat the patient exactly where I found them, and I remember doing this to in CPR classes. You put the mannequin under the table and you'd have all these people doing CPR under the table instead of moving them out. And the point was well taken that there was no reason we couldn't just pick up a baby. I mean, you can't always just pick up somebody and move them, but yeah, you probably can. You know what I mean? If you really have to have all your resources together, because when you split bags, those bags aren't meant to be, here's mine, here's yours. They go together. At least, that's how ours are, is that everything is, I got my drugs here, I got my laryngoscope here, I got my BVMs over here. And so I just was thinking about that. And I always whenever we do simulation or I'm going to an MCI, I always think about the fact that, you don't have to treat the patient exactly where you find them. If it's easier and you can do more good for more people by huddling together and taking care of these two red patients out of the same bag and the same, collection team, I feel like that makes way more sense.
I couldn't agree more. And always with the caveat, because we're talking MCIs, of things that shouldn't slow down, your movement. And again, if the patient, you need to control their ventilations in order to be able to move them, et cetera. So with that being said, control your environment. And I say that whether your role in this is a provider, like you were describing, a clinician, or someone who is in the command system and, managing the area. If it's the treatment area or the transport area, allow providers to control their environment. And it's so funny that you say that, because I remember being shocked when I was doing evaluations of NREMT paramedic scenarios. Like, we were evaluating the scenarios that they were going to be using, the clinical scenarios back in the day. And every single student, we would do something simple like just have a recording of a dog barking, or the television was up too loud or whatever. And I'm watching all of these students come in, and they were so practiced at, just like all of us, just deal with it. Just deal with, you're always going to be in a situation that is suboptimal. Just deal with it. So that
we intubate in ditches.
Exactly. Hanging upside down, leaning across the hood of the car, doing an ice pick maneuver through a broken windshield. And because that's part of our training and so we need to control our environment, because so often we can do that. We can't make it perfect, but you can control your environment. So look around, control your environment, and put you guys together.
Absolutely. Well, Rommie, I can't thank you enough for coming on, man. Is there anything that I'm forgetting, anything that we should end with as the do's and don'ts, or with the do's and don'ts of MCI, your first 5-10 minutes?
I feel, thank you for a great discussion. I feel like we really have hit those things that I have refreshed in my mind, that I hope everybody else is thinking about. It's that come in, stop the killing, stop the dying, and moving patients forward. Not without care, but moving patients forward is the big change for the MCI mode, not how many patients or any of the other stuff.